Welcome to Innovation Insider. Thanks for joining us. Today I'm joined by David du Plessis. I'd like to introduce David and I first met a number of years ago when we were both working at one of Australia's top health insurers together. Immediately connected, not just by name, but by nature. In the past few years, we've both moved into the world of consulting in very different paths, but in a similar space, particularly in healthcare and the relationships with health insurers. David has a whole wealth of experience in healthcare and insurance. He's worked for a number of large organisations, including NIB, Bupa, Honeysuckle Health, Catholic Healthcare, Healthy Care Australia. He's also an advisor for a number of healthcare startups and a founder who runs a number of different businesses on his own. So he's a very busy man. But David, thanks for joining us.
My pleasure. Good to see you, David.
You too. So David, today I want to talk to you about innovation. And I know you're very much a thought leader in the space of innovation in healthcare and very knowledgeable across the health value chain. So I'm hoping to unlock some of that knowledge and share that with those involved and those who want to follow along. So the first question I'll ask is around secrets. And what I'm hoping is if you can share with me what you believe are the critical ingredients or the secrets for effective corporate innovation.
Oh, I was hoping you wouldn't ask that one as the question. Corporate innovation, it's interesting, right? I think both you and I, when we first worked together, worked for an insurer that was quite innovative, quite dynamic in the way it approached itself. And both of us would sit inside that insurer and go, oh, we just feel like it's too slow. Things just can't get done. My experience working in other organisations after that, though, was, God, I wish I was back there. It's a little bit of a strange sort of dynamic. I don't know that in any organisation you ever feel like things move fast enough and that things are ever innovative enough. But when I think back on experiences of companies that I've worked in or worked with now more recently that get it right, the takeaway sort of leading factor, and I think it is culture. It's got to start with executive culture. And it's got to be an enablement culture that goes and flows through the business that really generates and creates that. Most of the really dynamic innovation that I saw come out of insurers and also in healthcare providers or in some of the startups typically doesn't come from your senior executives and your high-level managers, right? It really comes from people that are in direct application of healthcare. They're in the direct service provision. They're dealing with customers. They may be dealing with providers, supply chains, something like that. And they tend to think of innovation or come up with the concepts of innovation because of frustration, right? It's something that's a pain point for them. It's a pain point for a customer. They just become almost sort of enamored with the idea of how do I fix this and how do I drive that? And the big problem, I think, in companies that struggle with innovation is that they're not really creating an environment that wants to surface that type of information and then enable those people to try and lead it through. And I think the companies that do it really well, they tend to have that better culture around it. They tend to find those people, they tend to encourage them, and they tend to let them have some form of ownership in the development of that sort of process through. So I think that's the first one. The second is, and it's linked a little bit in that first component, but the second I think really is making space inside your strategy, in your finance, in your commercial thought and thinking about innovation and being dedicated to that. There is not a company I've worked in that has enough resources. It just doesn't happen. And so you're going to end up in a pitched battle on some good ideas that make a lot of sense, that are part of traditional strategy, coming up against some things that are innovative, that can really make a big difference, but are really harder to sell, harder to explain, and harder to dedicate through. And it's almost like adopting that startup think tank type mentality of going, well, how do we create enough opportunity here around these ideas to be able to take them to a maturity level that we can compete against that resource sort of pool and allocation? And give it a fair shot versus, every single time it comes up there and it gets into a priorities meeting and, someone's trying to test it against a business case that's had, months and years of effort and finance managers involved. And you just go, oh no, we're not going to do that. We're going to build another theatre if we're a hospital because we know that, or we're going to run a new marketing campaign because we get that as an insurer or whatever it may be. So that second component, I think of, well, how do you make that resource space and time available to take those ideas and mature them to the point where they can compete for resource allocation, and then invest into them, right? Obviously driving through. The last part, I think, and this is the last sort of thought I have on this space, because it's, in corporate culture is so different from one organization to the other. And this goes across all those resource projects, is I see so many companies failing to measure everything that they're doing well. We're really good at saying we're going to do this, we're going to run this project, we're going to implement this as an outcome. We're really good at initial financial forecasts and timelines that we then miss completely categorically. And sometimes when we do it really badly, we're really good at sometimes looking back and going, well, what did we do wrong on it? How do we learn from it? But if you were to rank the consistency of an organization in how it measures success from what it's trying to do, and not necessarily in a punitive way, but just in a very realistic sort of upfront way. We set out with this innovation to do A, B, and C. Did it actually occur, right? Because quite often when we fail at things, we're very good at just making them grey failures, right? We don't celebrate our failures very well, which means we don't learn from them, right? And when we have a really good success, we're very, very good at sort of patting everyone on the back and awards nights and things like that in corporate entities. But the reality is, if you were to actually measure the effectiveness of each project that you've dedicated resources to and held it to an account on, at the point of inception, it was supposed to achieve A, B, and C, and did it actually achieve A, B, and C, then I think you can't really claim that you're going to be able to be innovative unless you're actually testing it that way. So
love it. Thank you. One of the very first things you said there struck me when we worked together, and I feel like it's an innovator's curse, is that whatever organization you're in, you're not moving fast enough, but from the organization's perspective, you're always moving too fast and trying to break things. And it's the innovator's curse. Like, we haven't quite found a way around that one yet.
I think it's the corporate innovation company's curse as well, not just the innovator. I mean, for a healthy innovation company, you need a natural tension there, right? You need enough tension for doing things at an appropriate speed and being able to invest and do things properly, right? And I think with people like you and I, we've got this sort of headstrong mentality of just running at problems really, really hard and wanting to get things done really, really quickly, and that's great. But you need to create the right tension in the environment to enable people that are those natural innovators in your company to be able to achieve that, but do it in a mature way or a reasonable way, right? Because other people inside the company may not be able to keep pace. So that's a risk there. Yeah. But the other side of that curse, the other side of that coin, is if you stifle people like that and you have too much internal resistance as a corporate entity, you lose really talented people very quickly, right? And then you end up with a very mediocre, great doer type employment base, right? You've got a really good, consistent service delivery model. You've got some really great, consistent, standards and qualities of service and things like that, but you're not really changing. And the ability to compete in the modern marketplace is an ability for a company to rapidly innovate and either keep pace with its competitors or outstrip them, right? First mover advantage tends to be your better advantage in health insurance because it's an easier gap to close for competitors. Healthcare is a little bit different, right? First mover advantage isn't as important there because there's some stronger barriers to entry in some of these things. But if you get that corporate tension wrong, you can actually have some big long-term cultural issues in trying to even reinvigorate it, because trying to attract talented innovators into a stifled, closed in corporate environment is very, very difficult. And once you've lost those people, they tend to network together, and it's like, well, no, I wouldn't go back there. It was too hard. I couldn't get things done, right? They just want someone that's going to tick the boxes and do A, B, and C. And that's not me, right?
I love it. You're spot on. The difference between genuine innovative thinking and sort of, I guess, process and kind of ways of working versus an execution mentality is completely different. But it's interesting because some organizations believe they're innovative and they have that culture because they are really good executors and they can get things done. But I think that links back to your kind of measurement. Is it like, okay, we did a bunch of stuff, but did it really have an impact? Was it effective? Did we shift the needle? So that's really interesting. But maybe just if I take those kind of three strands you talked about, culture, strategy, and measurement, as the secrets to innovation, what I'm hoping you can tell me, what do you see? What are the things that are getting in the way? What are the barriers? What are the things that's stopping corporate innovation? or corporate, innovators being able to set the right culture, set the right strategy, and set the right metrics and hold themselves accountable to those?
Yeah. Oh, culture's the hardest one, I think, to breach in that, because it comes from such a top-down type view. For innovation to really thrive, it needs to be built into the DNA of the company. And so you have to have the right leadership, and you're not going to go and switch out CEOs and CFOs and CTOs and things like that very easily, quickly. And quite, generally speaking, they're the decision makers on culture, right? So if they're not buying into that, they're not going to reset themselves and opt out to say, well, let's bring someone else in to replace me. So that's a hard one, I think, to change in that aspect. And you see a lot of the adoption of the language of innovation, agile, and the process and things like that gets talked through in the middle layer. It's not really understood at the top, or whatever it might be, in the more sort of modern terms and things like that. But the reality of it is that the culture at the top needs to be that enablement culture, right? You don't necessarily need to understand the technical detail if you've got the right people for it. And so where you don't have that really strong executive alignment around these areas, that's, I think, the first big challenge and barrier in culture. And what I mean by that is you may have some really, really strong business units or areas of business that can innovate, but there's so much complexity in modern business today, particularly in insurance and financial services, whether it's general insurance, health insurance, even in your banking sectors, right? You're really causally reliant on working well with the other parts of business to be able to get anything done, right? It's very rare that you see a complete ownership of a process or experience for a customer or a supplier or whatever it is, just sitting in one area of business.
Mm-hmm.
So if you've got a lack of executive buy-in on that cultural piece across the executive, that'll flow down into their areas, and your barriers actually become sort of this interplay between fast-moving segments that are really putting pressure on trying to get outcomes, and a sort of stagnant culture in other areas of business. And the clash between there then creates a whole bunch of secondary issues, right? That's not just an issue of the fact that you can't innovate, but then it creates sort of barriers of us-them type mentality. You start having sort of breakdowns in processes, and then you start having further breakdown in relationships and the normal standard business process, right? So you can see how if you've got a really strong innovation segment in business that's enabled, but it doesn't consistently flow across other parts of business, it can actually create these other sort of intrinsic issues that then become almost impossible to overcome. And this is where I've seen some big failures before in corporate Australia, right? Is where there is an intent around innovation, and then there's an investment into an area of business to lead innovation, and it creates almost this internal resentment, right? Okay, the plebs doing the doing, keeping the customers happy. We've been asking for stuff. We can't even get the this field in this program that we use every single day updated, and here we've got this team that just gets money and resource and time thrown on it, and they keep on pulling into meetings and talking about this latest methodology and this, that, and the other, and we're going to iterate and prototype and MVP, and all I want is the screen to work for me, right? And so you create these sort of really weird tensions, and so you can't really. There will always be natural parts of the business that will be reliant on innovation, particularly in modern business being so IT driven and digital in the nature of it, but you can't have innovation segmented into that part, and I think that's the big one in culture. Strategy is easier and harder at the same time. It's a very, very clear view as to whether or not you want to be on that leading edge or not, and every company needs to make that decision themselves, right? It's not the right decision for every company to say, I'm going to be the market leader in this, in digital first, in whatever it is, because you may not have the resources or the allocated right inside the industry to be able to pull that off, right? Mm-hmm. If we were to use the insurance industry as an example, take NRB and Medibank, two listed entities, quite large scale, quite well resourced in different ways. The customer base is so dynamically different. You're going to have a far better response on a digital leading, digital first type strategy with an NRB, because you've got a youth aligned brand, right? The adoption and the intent and the inherent perception of what expectation is for that customer base is radically different when you look at Medibank and an older population that likes the walk into the stores and the storefronts and things like that are now being progressively closed in the insurance space, right? Very, very different. And even for Medibank to think through its strategy, very, very different to AHM as a brand versus the Medibank brand, right? So the first part of that strategy is being very clear on what your intent on innovation is in your strategy and how much buy-in you have on that in fulfilling that strategy, because there's sometimes far better, more conservative approaches that fit the market segment you sit in as an organization. Doesn't mean that you shouldn't be innovating, but how much and where you innovate changes very dramatically on that strategy, right? And then allowing that to flow through becomes key.
It's really interesting, and I really like the comparison you gave there between NIB and Medibank, right? You've got one player around, say, 10% market share, one around 25, 30% by memory. I've got this assumption that those who are within Medibank might be envious of NIB because they've got a responsive, likely a responsive base to digital health initiatives and kind of new things. They think, oh, they're a much smaller organization, they can move faster, they can do all these things. And then you've got people at NIB who would be absolutely begging to get access to the size of the database and, to send out, to run a campaign or develop a product and get 10,000 users could be unimaginable for a business like NIB, but at Medibank, that might be a bad result. So there's that whole scale thing that's really interesting as well.
Yeah, and the biggest mistake I see companies making in innovation and scale business at the moment is around data and machine learning and AI. There's some really big fundamental misses that I just see in that space in the use of innovation. And it's really sexy to talk about and say we've got an AI strategy and we're doing this and that and we're machine learning this, right? I think every single time I talk to most companies around that, I vomit a little bit in my mouth because I'm like, well, there's so many simple things that you're not doing great at. Really, is this where you should be spending time and effort on that? But I think fundamentally where I see the challenge around this and the scale part is, a lot of that technology is really based on the quality and the volume of data that we hold, right? And even our big scaled players inside our healthcare environment, whether that's on the provider side with Ramsay's and the Health Scopes and the St. Vincent's of this world, or the insurers, the Bupas and the Medibank, even they are struggling to have enough volume of data to be able to really do insightful things with machine learning and AI, right? Now, there are definitely areas where it's easier because of transactional interactions and, time of day, when's optimal service time for you as an individual versus me as an individual and things like that. But when you start looking at some of the attempts to apply this into understanding sort of forward-looking healthcare needs or, understanding relative returns on did this provide a better outcome for a patient or not, right? I think it's actually really, really hard. And I don't know that a lot of the companies that have tried to get involved in that space, particularly the smaller ones that don't have that scale, even have the quality of data, let alone the quantity of data to really derive value from that as an innovation project, right? So there's this, attractive nature to get involved in what really looks cool at the moment in industry. But when we sort of set that conversation about, well, what's our strategy? Well, that, if you're a Medibank and you want to play in machine learning and AI in the space, it probably makes sense. If you're a Bupa, it probably makes sense. Look, if you're a teachers' health fund, it's probably going to be really, really hard. And the relative value and return on it's going to be so low compared to the cost. What are the other things you can be working on, right? Like if you're a defense health, all of these sort of middle layer players are probably going to really struggle around that. But it's really, really cool to sit at your boardroom and talk to your board about, hey, we're doing this AI-led strategy and this, that, or the other. And, we've got these machine learning models doing A, B, and C. And it's like, but what about our just standard quality of service? What about our telephony platform and what we could be doing there? And what about how we could think about innovation and things like that, right? And how do we step away from innovation just being about technology and think about the other aspects of what we actually do as incumbents in the industry, right? So
we're just trying to keep the lights on rather than necessarily we're a few years behind because they're just not as well resourced, right? Like they're not as well capitalized. They don't have as many customers. They don't have the luxury of just hiring and kind of deploying and employing these kind of initiatives. So it's really interesting, and I think health insurance is a particularly interesting space because you have got around 30 players fighting for sort of 10 or 15% of the market, which which is really a really unique market in that way, because you've got the top 5 who sort of make up that sort of 80, 85, 90% of the market. Speaking of insurers, I'm keen to dive into this because I know you've been quite vocal and you've got definitely a thought leader in this space. I'm interested at the moment. There's a lot of industry tension. There's a lot of media sort of playing out. We've seen recent negotiations sort of, or lack of negotiation, fall into the public domain between St Vincent's and NIB. We've seen Bupa take a stance. We've seen Medibank take a stance. We've seen Ramsay. We've seen Healthscope and their owner Brookfield, come out publicly and talk about this. So a lot of tension between insurers and private hospitals in the current environment.
Yep.
I'm keen to get your perspective on the key issues that are driving this tension, and maybe you can give a bit of a layman's view on what is actually happening here, but particularly interested to understand what is kind of, how have we got to this point, and how do you think we're going to kind of get out of this, and how are things going to play out in the future? And then lastly, what role does innovation play on both sides of the party to kind of get us to a more balanced and I guess equal society, or not society, or industry where everyone feels like they're valued?
Yeah, this is a complex issue, and I've stayed out of the more recent sort of, I suppose, stash between Healthscope and / Brookfields and PHA over it, with Bupa and the HSA sort of getting pulled in. Fundamentally, we've got a few issues inside healthcare in Australia, right? There are some structural issues that we need to really deal with as a entire society. Putting aside private health and public health and state and federal, we've got this inordinately complex system, and unfortunately, it's also been a system that over quite a long period of time has driven, particularly in private health, this segmentation of profitability. Who's making money, and how do they exploit that money off the system in many instances. So I use the word exploit intentionally and unintentionally. I know it'll probably sort of get some people angry, but the reality of it is, when we think about how the entire system sort of works and operates, in many instances, the use of a private insurance mechanism is another way of having a different form of taxation into healthcare based on relative earnings, right, for Australians. The problem I think we're facing at the moment is that because of the community rating, the mandatory participation system, we have to have some form of strong regulation around health insurance. And we do. We have some incredibly strong regulations and legislations and business instruments and rules around how insurers operate, their mandatory reporting. We even price regulate them with targeted price margins of around about 5 to 6%. And that's all done for the best intent of the consumer and keeping health insurance affordable. And that's really important for the whole of Australia, because the participation in private health relieves a lot of pressure off our public system, right, particularly in elective surgeries and wait times. The problem you have when you price regulate a single aspect of the market, and particularly when you do it at the apex of that market, is that it flows down through that market, right? As an insurer can only price their products based on approvals from the government, they have a capped revenue earnings. They've got then to manage their margin below that. And ultimately what we end up seeing is the cycle where insurers are doing really well, and that's the cycle we're in at the moment, and hospitals are really struggling. And then the reversal, that where hospitals start doing really well and insurers become very, very marginal or loss leading, right? Now, you go just before COVID, we had the death spiral of private health insurance, right? And there's lots of articles by the Grattan Institute and various health economic agencies about the fact that health insurance was really struggling. And the major driver of that was a few things. One, premium revenue increases, even though they were quite high for consumers, weren't meeting the inflationary costs of care. And the second, probably more important drivers of it were that we were having, the good risk young Australians falling out of the system. They weren't seeing value in holding the insurance. And it's the same as the sort of aging population and taxation issue. The more taxpayers we have, or the good risk that fall out of the system, while we're having an increase in the retirees or the bad risk sitting in the system consuming those services, then really places pressure very, very quickly into a health insurer, right? At the same time, leading up to COVID, we had this really strong growth in volume in the healthcare system. So not only are we getting price increases because of the natural inflationary costs of just delivering healthcare, we're then having quite strong occupancies and growth, lots of beds being built, lots of hospitals being built and opened, right? And what that basically meant for health insurers is that their revenue line compared to their cost line was closing, and that was the death spiral. When those two intersect, obviously you're starting to make a loss, and then you start seeing insurers close. We're in the reverse of that at the moment. Insurers post-COVID are really, really good, and mostly that's because of two things. We've got a lot of people that are returned back to the system. Bad risk has been offset by a lot of young people coming back in and viewing health insurance now more as a health insurance product than I just have this because of taxation, right? I want to be able to go to a private hospital. I don't want to have to wait in the public system. The public system's under pressure. We can see all the bad news there. So we've had some really good return that's come through there. At the same time, post-COVID, we've had this continued decrease in the volume that's occurring in the system, okay? And so for hospitals, now what we have is less participation relative to the beds that they have. At the same time, for hospitals, we've had this massive increase in costs. You know, the inflationary costs to hospitals are very real and are going to be deadly for some of these small hospital providers, right? We will see continued closures of them. Now, what's driving that is supply costs into Australia are really high. Inflation on that is quite high, right? But the secondary and the primary driver is labour costs in Australia, right? Our nurses, and predominantly our nurses and our caregivers and administration teams, and then also the doctors employed there, because of the continued increased cost of living and inflation for general consumers, that wage increases are driving most of the cost increases to hospital. And we're seeing increases of 10, 15% to nursing EBAs at the moment, right? Really, really high increases, and they're needed, right? They absolutely are needed, but hospitals now need to deal with that. And so hospitals are now facing this sort of revenue challenge. They're not getting the quality of revenue and the volume of revenue through, and they've got these huge drivers of cost. And so, quite rightly, they're saying, hey, if this stays this way, we need to be paid more for the work we're doing. We basically need health insurers to come to the table and pay more for that, right? And that's the environment, right? Like it's a complex but a simplistic problem, right? Costs are outstripping the revenue growth for hospitals, and the problem is that when hospitals close, it creates a lack of supply for consumers, right? That then translates into pressure on the public system. So it's not great for anyone. The stoushes that we're seeing between big insurers and big hospital groups are not helpful in this space, though.
Okay.
I am not worried about a Healthscope closing. I'm not worried about a Ramsay closing. I acknowledge that they're under significant pressures and that they're making less profit than they've ever probably made before, and that they need to address that, right? But the providers that we're going to start seeing closing that are going to really hurt consumers and really going to hurt the industry are small independent hospitals, overnight hospitals and day hospitals, small groups, because they are not deriving anywhere near the quality of revenue that a Healthscope or a Ramsay or a St Vincent is getting out of their contracts with health insurers. They don't have the market power to have gotten really good rates in their negotiations, right? So they've already been working on very fine margins, and health insurers have really nailed that part of the market down in negotiations over the last decade, because that's where they try to save their money, because they've been paying probably more than they think they should have to the Ramsays and Healthscopes in their negotiations. And so when we start seeing these closures, we're going to start seeing them in that segment of the market, right? We're not going to be seeing a bankruptcy declaration from Healthscope or any notifications to the market from Ramsay on that. They are hurting. Absolutely guarantee they're hurting, but I would question that they're running at a loss. I think that's a very unrealistic statement to be making about that. So ultimately the system is designed to keep this confrontation, this tension going, and we need some way to diffuse that. If I was to step back as a consumer of healthcare and be watching this, I would not have confidence that we've got the right healthcare system at all. There are so many people that keep on talking about how my healthcare should be supporting their profits in this segment, right? As consumers, I think we should, and this is, I think, key to sort of innovation, right? When you think about innovation, you need to think about the problem from the right way, from the right lens, right? And I think it's really easy to understand when I sit in like the seat of a Healthscope or a Ramsay or a St Vincent's as to what they're doing and why they're doing. And if I was in their seat, I'd be running those strategies too. Same for the health insurers. I can see their requirements and their returns to shareholders and their forward-looking risk around what will happen when volume does pick up, and it will pick up, and they do have some significant risk around that, right? I can see from the AMA's point of view why they keep on barricading on about doctors need to be paid more, things like that. But in the end, when I sit there as a consumer and I can see that doctors are consistently over the last decade at least the top 3 earners on the ATO tax list by profession, when I can see the listed outcomes of Medibank and NRB in regards to profitability, when I can see the same for the Ramsays of this world, and then I can see them all fighting saying we need to be paid more, it's really easy to become really cynical very quickly about whether or not private healthcare in Australia is working for consumers, right?
That's interesting. Yeah.
It is a really, really interesting question, because if I was to sit there and think about, hey, if I was designing a system from scratch right now, would I design it this way? And there is no way that I could think of fabricating the system in the way it currently exists, other than if I was designing that system with a very strong view of returns to individual stakeholder constituents of that system from a financial point, right? It's a really, really hard thing to sit there and say, hey, as a consumer, when I access into the system, is there actually anyone here that is looking after my best interests in regards to my affordability for insurance, the quality of my care, my out-of-pockets when I need to access those systems and services, and the outcomes that I'll actually get from that, right? And I'm not seeing anyone sticking their hand up going, hey, we tick all of those boxes right at the moment.
That's really interesting. There's a lot of money made in healthcare, isn't there?
Not only is there a lot of money made in healthcare, I think we've got this very myopic view, and we've had this narrative as Australia for quite a long time that we've got this amazing healthcare system. And we do have an incredible healthcare system in regards to the standards and the qualities and of care that is provided. And to my mind, that's mostly led by our medical specialists. But they are also probably some of the highest paid medical specialists in the world, right? So we are investing, in a sense, in that quality. The question is it sustainable? And is it measurable? And are we actually achieving those outcomes? Because if we've got a system that is that good, but will implode on itself, then what does that actually leave us with at the end of it all, right? And at the moment, I don't know that we have a system that is sustainable, because we have too many contingent players worrying about that sort of profitability, that viability component. And they should be, and that's necessary as part of it. But from a consumer point of view, is this the right system? I don't know.
Well, maybe I love that. Well, maybe let's use that as a platform for the next question. Let's say we're in the world we're in.
Yeah.
And there's 2 scenarios here, and I'll let you pick which one you want to take. So path A is we blow it up and we start again. What's the future of healthcare in Australia look like? Option B is we are where we are.
Yeah.
Where's the future of healthcare in the next 5 to 10 years? We don't get to blow it up. We get to try and fix it how it is. And we use innovation in both of those ways.
If we think about where it will be in the next 5 years, we're going to continue the cycle. Whether or not something will need to be done to address the viability issues for hospitals, it will more likely be government-led policy change, something along those lines to force it. I think the ramification of that will more than likely be that we're going to return insurers back into their death spiral very, very quickly, and then we're going to have the same sort of issue. So there are some fundamental changes that governments made over time that would need to be reversed to keep the current system going, and by that we're really kicking the can down the road by sort of 10 years. So a few things around that would be in addressing some of the decoupling of the rebate to the premium rounds and coupling it to CPI and things like that, because it's driving some of the affordability issues for consumers. I think there would need to be some form of addressing medical out-of-pockets and the associated secondary costs of access for healthcare, because I think one of the occupancy or the capacity drivers for hospitals at the moment that's keeping a lid on activity is we've got so much consumer-based inflation and cost of living pressure that there are a lot of consumers out there that I think need to access services but are choosing not to because they can't afford the cost of accessing healthcare services through medical specialists at the moment, right? Now, when those inflationary pressures and cost of living pressures reduce, there may then be a potential volume that'll throw itself through the system that may or may not be ready for. But that, I think, is a relative risk, because when we think about Australia, once again, I'll go to this view of, we talk to having this amazing system, and the use of the word universal healthcare in Australia should be banned, because we do not any longer have universal healthcare in Australia, right? You cannot go and see a GP without paying money. There are people in Australia right now that choose to not go to a GP when they need to because they cannot afford it. You cannot say as a country we've got universal healthcare, that Medicare is working for Australians at the moment. It's a categorical lie, right? Even going into state-funded public hospitals, there's this increased attack of the public health system on private insurance to use that in public hospitals so that they can get some secondary funding through it. That's been going on for years, but now we're seeing the doctors involved in the care at a public hospital charging out of pockets to a patient as part of their public hospitalisation, right? There is no longer universal healthcare in Australia. So there'd have to be some pretty big structural changes just to keep the system going for the next 5-10 years. And we would just see the difference, in 5 years' time, is it'll probably be insurers screaming about viability, and the government needs to do something about it, right? Like it's probably just going to be a return to that.
Yep.
Look, on the blow it up option, I think there are a few different ways that you could do that. The way that I would think through, because you can't just remove this, it's so intrinsically bound to our system. You can't surgically remove private healthcare from Australia. It is such a core part of the service delivery model. What you could do, though, is go, okay, well, if you're bringing value, so let's take that consumer lens. If you actually bring value to consumers as an insurer, then let's remove all the incentives and let's remove all the penalties. Let's remove the Medicare levy if you don't hold insurance, but let's also remove the rebate if you do, right? Let's make the insurers show the value of why you would hold private health insurance to that point, that people stay and hold that insurance and are willing to pay for it as a standard insurance product, the same as you would with any other insurance product, right?
Yep.
That would have a pretty catastrophic effect on the system. You'd probably see the insured numbers drop from sort of 46, 47% they're currently sitting at down to probably more like what we see in New Zealand, 25 to 30%, right? And mostly that population would be people that view health insurance as a risk product. So people that are sick, that are going to access it, it'd have to be risk rated individually, not community rated anymore. The premiums would be quite high, right? It'd be quite catastrophic for private hospitals, because all of a sudden the participation of the insurance mechanism has just completely reduced.
Yeah.
And so the volume there, the system's built around a capacity and a participation of around 45% on bed numbers and theatres and things like that. So they would have to show enough value to make it sensible in regards to premiums being affordable and to keep capturing volume, right? Likewise with doctors, they'd have to be able to show enough value to be able to capture that private component of the market, which means that price sensitivity becomes far more reliant. So that's one way of doing it. You basically make it a free market. You say, well, if your insurance is so good and you're actually bringing value to consumers, prove it. We're going to take away all the penalties and the incentives. You're going to act like a standard insurer, and let's see how you go, right? Likewise for hospitals, if you can't bring an efficient, effective model of care and provide care in a way that makes that insurance affordable for insurers to be able to use, then you need to find volume somewhere else. Now, that might be doing work for the public sector, it might not. Like there's a whole bunch of issues there. But that's one way of doing it. Right? You could just completely blow it up by going and just then letting the market then actually exhibit the value that it brings, right?
Yeah, that would be really interesting, right? Because if you think about that insurers unbound by some of the type regulation they have, it would be interesting to see where they go and how quickly they do look at expansion across the health value chain and into alternative, services, probably a tighter role in, or a more active role in primary healthcare and things like preventative health, things like that would be really interesting, right?
Well, I think they would have to move into those areas and show that value. And look, there are other models. Instead of blowing it up like that, you could say, okay, well, look, the Medicare revenue that's generated by an individual that holds insurance is all given to the insurer, and they deal with all the consequent cost for that population, right? Let them take on the full risk. Let them see if they can manage that population better, and the ramifications downstream then on, well, where does service provision fit, and how does that look in the future for Australia. So there's a few ways of thinking through it, but there's no easy way of doing option B, right? Like there's either way, we're going to result in some form of catastrophic reset of the market in regards to, are we over-resourced? Are we over-indexing? Are we over-utilizing? Are we over-insuring, right? Are we bringing value or quality to any of that? And are we actually relieving pressure off the public health system? And, in that option B, what you would find is that public health would be flooded, right? Like they wouldn't be able to deal with it. And there is, I think, better opportunities for public and private hospitals to work together and an outsourcing model. And we see some glimmers of it done well with Queensland and the way that they sort of outsource through a sort of centralised model and that. But the reality of that is that there is access and opportunity efficiently and effectively through private hospitals for public health to leverage off. And they would have to naturally look at that as a solution. So, when you talk about decoupling that rebate and removing the rebate and the tax incentives and things like that, you probably have to then pace the Medicare levy up a little bit to compensate, and you probably need to take all of those savings and allocate them down into federal and state health to compensate that system, right?
Absolutely. No, it's interesting you talk about the example just used there in terms of established private hospitals, and we may need to innovate because their capacity would be it'd be interesting. It's interesting how quickly organisations can move when their back's against the wall. And I think, correct me if I'm wrong, but when the pandemic kind of really hit, private hospitals were forced to innovate and work with the public system and offer that exact solution, where there was supply issues from public hospitals. There was capacity issues from there was demand issues from private hospitals, so they did work together to be able to manage some of that oversupply, and they were able to move quickly. They were able to innovate effectively, and find shared value across the for the benefit of consumers, right, or patients.
Yeah, absolutely. And I think that's what we keep on losing focus in all these conversations. No one's talking about, like, really what's the value proposition there. Look, there's middle ground, I think, in a lot of alignment here. There needs to be far better alignment on the way we think about funding into healthcare and alignment of self-interest with patient interest, okay? There's too much alignment of payment with personal interest in the entities and the individuals in the contingent players. But where healthcare tends to work really well is you need to understand, particularly in private health, that the biggest factor of influencing the way that care and quality of care is going to be provided is how you fund it, right? And if you don't like the behaviours you're seeing in the system, then you're not funding that system correctly. And that's, I think, some of the major struggles we have here. We've got such a complex system with variant dollars coming from federal health, state health, consumer pay and out of pockets, in private health insurance, right? People leveraging off their superannuation. There's this really, really complex system in the nature of there. And what we really need to do is simplify that and go, well, look, what happens if we would just go, let's stop letting insurers and hospitals play together? They clearly can't. If you put them in the same sandbox, someone's going to get sand in the eye and there's going to be a tantrum and a fight, right? And maybe what we should be looking at going, well, let's look at how we regulate pricing, and we maybe fund everything directly through singular doctors. So, a health insurer funds a set amount for a major joint replacement, and that amount is indexed and managed maybe by IHACPA or organisations like that. And that money is paid to the doctor. That's all the doctor gets, that with their Medicare component. How they manage that downstream in regards to how they want to innovate in models of care, if they want to use outpatient service providers to shorten or reduce the length of stay, if they want to have discussions and negotiations with hospitals to get preferential rates that make it more efficient or effective, if they want to have conversations with medical device companies over, better pricing for those same devices rather than a regulated price framework, and they're able to bring certain volumes to make that more attractive to that device company. It allows more free market dynamics to occur below there. But if you have that sort of singular funding component with the doctor and you align that with then also measuring their outcomes, because if you're going to give them the opportunity to make a lot of money by playing off the contingent players beneath them, you need to make sure that it's not at the cost of the quality to the patient. You measure their quality, you provide them with the funding, and you let the downstream market sort of flow through and play with that. That's an interesting model to me, right? Because it simplifies all these individual contingent players being able to leverage the complexity of the market to exploit it, right? Well, it's a single pay, right? How that works below there, really up to you as a medical specialist and practitioner. If you can do it better,
love it,
and save money and make yourself more money off that, then that should be encouraged and celebrated, as long as the outcomes for the patient are consistently good or improve from that. And if they don't, then you should pay a penalty on that.
Love it. I was going to ask you, next question, I was going to ask you about an unpopular opinion you hold. But I think you've managed to share plenty. There's enough there to get our specialists and doctors and insurers and hospitals.
I like the idea of the specialist model because, I do a lot of work with doctors. I spend a lot of time with them, and I've done some work with the AMA. And there are some really bad examples out there, and we see the Charlie TOs in the media and things like that. But they really are the exception. The vast majority do the right thing by their patients, really care about it. And the vast majority are really frustrated by how they not innovate in healthcare, right? They're really stuck in this antiquated fee-for-service Medicare model that is managed so progressively slow with MSAC approvals after TGA approvals on devices and things like that. And their ability to implement what they know is best practice internationally can sometimes be 5 or 10 years in Australia before the funding mechanisms catch up to it, right?
Wow.
And if they want to access and use different pharmaceutical agents or different devices that aren't sitting on the prosthesis list or the medical devices list or the PBS and things like that, it sometimes locks them out of providing care the way they want to, based on what they know is the best way to provide it for their patient. And that tends to also bring secondary efficiencies in the health economy at a later stage, right? So with the right checks and balances, having a better framework around enabling clinicians to innovate in Australia and supporting that with the right funding mechanisms, that becomes quite exciting. And then you can see how hospital providers could adapt their models of care to become more functionally aligned to supporting that activity and enabling it to capture that relationship and hold those relationships, sort of business to business sense with that medical specialist, right? There's self-interest there. If they bring all that work and I can help them run their business and help them develop these models of care, maybe run them on their behalf, yes, they'll have to pay me for that. But I'm far better to run a hybrid model with outpatient services and my hospitalisation component than to just be the hospital contingent player and someone else is getting that nursing care in the home part of the bucket or whatever it might look like. So I think if you think about innovation, you can be a little bit more radical. We really need to think about how we align funding mechanisms with patient outcomes so that when someone wins financially in the system, the patient has to win with them.
Yep, I love it. Thank you. With that, I might get you to, I know you've got your fingers in a number of different pies, but maybe it's the opportunity to tell you, I know you sort of run Ala Consulting and you spend a lot of time with across the health value chain with lots of different players, small and large, but I'll give you the mic and sort of let us tell you about your Ala Consulting, any other ventures that you're currently working on that you'd like to talk about?
Yeah, so I mean, my primary consulting, I spend a lot of time talking about these things and working on strategy with various players. I do some work with insurers. I spend a lot of time with providers at the moment, just given how tough things are there and trying to support them in understanding their revenue strategies and optimization opportunities. And I do a reasonable amount of work on sort of health literacy, particularly with international investment communities. So getting them to understand how things work in Australia, because it is quite a difficult model to understand our federal state insurance mechanisms and community rating and things like that. So, when there are large transactions in the environment, typically I'm involved with, one or two of those companies trying to help them work through their investment thesis and those types of cases. So I do quite a lot of those sort of types of work in there. My other roles, I'm doing a reasonable amount of support with particularly digital-based tech startups in healthcare. That ranges through a number of different companies, and it's mostly sort of advisory work or mentorship. But I really like the Australian health ecosystem around innovation and clinical innovation that's coming through. It's seen some really cool things. There's a company I met with last week called Preview Health that has basically come up with a way of predicting someone's risk of Parkinson's disease in the next 15 years with a 94% accuracy, right? That stuff will change the way that we think about preventative treatment for Parkinson's and is really, really exciting. So Australia's got this huge talent pool of innovation in biotech, in deep tech, in health tech, in digital health. And I just love playing in that space. It's just really cool. So I tend to get involved in that, and I'm more than likely going to join the Founders X program with the University of New South Wales as one of their mentors soon, because I end up talking to their companies all the time. My passion at the moment is a startup that I'm involved in as a founder, which is called Severin. So it's in brain-computer interface, and we're literally building this really cool tech that will replace the use of electrodes to measure neural signal in people's brains to, help integrate the human mind with computers. So I've got this team of 5 scientists, sort of founders around me, and I'm categorically always the dumbest person in the room, which is great. And we're using this really cool liquid crystal-based technology to measure neural signals and fabricate these really tiny arrays. And that's been really exciting. We're in the middle of a capital raise for that, and anyone that's looking to throw some money into deep tech with a really cool company that's coming out of the University of New South Wales down in Sydney, then get in contact. But that's sort of what I'm up to.
Wow. And on that, are you looking for strategic investors, individual investors?
Oh, look, a little bit of both.
Sophisticated investors.
Yeah, we're probably targeting, because it's deep tech and that's just complex by its nature, probably more sophisticated and institutional investors. There are a few, I suppose, individual investors out there that would probably be interested in the space because of their background and all that, but typically it's been more institutional at the moment. So
cool. How cool. That's unreal. It sounds like you've got plenty on your plate. And for any leaders or anyone who wants to get in contact with you, what's the best way to get in touch?
Look, probably LinkedIn. Send me a message, drop me a line. You can go on my website, and there's you can pop some forms in there. But it's probably my website is the absolute proof that I cannot innovate in regards to a website. So I need to refresh and things like that. But yeah, no, look, probably the easiest way is to reach out on LinkedIn and just drop me a message, and I'm pretty responsive on there.
Okay, wonderful. Well, David, thank you very much for your time and sharing your wisdom. There's so much to unpack there, and clearly had a lot of deep thinking and understanding around the Australian healthcare ecosystem, and you've managed to articulate a very complex problem in a very simple way. So I really do appreciate that. And I've just written down here, I've written cult, strat, and measure, culture, strategy, and measure. As I guess some innovation principles that I think could really help corporate innovators as strategic pillars to think about how they can innovate more effectively. But thanks very much for your time, and look forward to catching you again soon.
My pleasure. Great chat. Thanks, Dave.